There are ways to prevent and treat neonatal RDS. If a baby is going to be delivered preterm when it's thought that there won't be enough surfactant present, the mother can be administered betamethasone. This is a corticosteroid, and as I told you before, steroids stimulate surfactant production in the baby. And then babies who are born with neonatal RDS can be treated with surfactant. It can be administered via an endotracheal tube, and this can improve outcomes in babies with neonatal RDS. Now let's talk about the lobes of the lung. The right lung is divided into three lobes, the upper, middle, and lower lobe. The left lung is divided into only two lobes, the upper lobe and the lower lobe. And the reason the left lung only has two lobes is because it has to make room for the heart. There is a small structure called the lingula that is a lobe-like structure and would otherwise be a left middle lobe, but it's not considered a lobe in and of itself. The lobes are separated by fissures. This fissure here on the right is called the horizontal fissure, and this one down here is called the oblique fissure of the right lung. In the left lung, there's only one fissure, and this is called the oblique fissure of the left lung. The most important thing to know about the anatomy of the lungs is how to identify which lobe is infected in the case of lobar pneumonia. So let's go through some X-ray examples of infection of each of the five lobes. This picture shows infection of the right upper lobe, and it's fairly easy to identify that there's a white haziness, a consolidation present in the right upper portion of the lung. That's the right upper lobe. Here's a pneumonia involving the right middle lobe. You can see this haziness here in the lung. Sometimes you can think this is the right lower lobe, but if you look on the lateral chest X-ray, what you always see in a right middle lobe pneumonia is this triangular shape right here. When you see that in the lateral X-ray, then you know that what you have is a right middle lobe pneumonia and not a right lower lobe pneumonia. And then finally, here's a right lower lobe infiltrate where the haziness is down at the bottom portion of the right side of the lung. Notice that it obscures the diaphragm border over here. That's classic for right lower lobe pneumonia. On the left side, here's an upper lobe pneumonia. You can see this haziness here in the upper portion of the left lobe of the lung. And then finally, here's an example of a left lower lobe pneumonia. Let's talk about foreign body aspiration, because this is a way that step one often tests your knowledge of the lobes of the lung. So foreign body aspiration can occur in any body, but it commonly occurs in children. They sometimes aspirate peanuts or small toys into the lungs. And what you need to know is when this happens, the object is most likely to end up in the right lung. The reason for this is because the right main bronchus is wider than the one on the left, and also it's got less of an angle. So when the trachea branches into left and right, the angle is less going into the right, and that's where an aspirated object is most likely to end up because it has the more vertical path into the right lung. So about 60% of cases, aspiration ends up in the right lung, usually in the main bronchus. A small number of cases are in the right lower lobe bronchus. The left lung happens in a minority of cases, about a quarter. It's usually the main bronchus. A small number occur in the left lower lobe bronchus. And here's a reference at the bottom of the screen here if you want to find out where I got all this information from. Shown on this slide is the relationship between the pulmonary artery and the respiratory tree. So the structure in purple here is the pulmonary artery. It branches into a left and a right pulmonary artery. Up top you have the trachea coming down and then branching. This is called the carina, where the trachea bifurcates into the right and left main stem bronchi. You've got the left one over here and the right one over here. What you need to appreciate is that on the right side, the pulmonary artery passes anteriorly to the right bronchus. You can see that here. It's passing in front of it towards the chest wall. That's anteriorly. On the left side, what happens is the pulmonary artery goes up over the top of the bronchus. It's superior to the bronchus. And people often remember this by the mnemonic RALS, right anterior, left superior. And on a board exam, they may show you this in a CAT scan, so let's go through that now. So over here we have the left lung, and over here we have the right lung. The carina is here. These two black holes represent the bifurcation of the trachea into the left and right main bronchi. You've got the aorta back here, that's the descending aorta, and the ascending aorta right here. And this is the pulmonary artery here, and you can see it bifurcating into the left and right pulmonary arteries. And the right one here goes in front of the bronchus. You can see that right here. It's anterior to the bronchus. It's toward the front of the chest. The left one here is going over the top of the bronchus, and it's a little hard to appreciate this in a 2D image, but you can see that it looks different than the one on the right side. Next, let's talk about the mediastinum. The mediastinum is the space between the lungs in the chest cavity, and it's divided into three anatomical compartments: the anterior, middle, and posterior mediastinum. And the way this comes up clinically is there are a number of masses that can arise in the mediastinum, and the differential diagnosis of the mass varies by which compartment contains the mass. Here's a CAT scan through the mediastinum, and let's go through the structure. So we've got the heart right here. This is the aorta right here. In the back we have the spine, and in the front we have the sternum right here. The anterior mediastinal compartment is everything I'm marking with my white pen right now. It's everything anterior to the pericardium between the heart and the sternum. The middle compartment is what contains the heart and the great vessels, and then the posterior compartment is what contains the spine and the spinal cord. On this slide I've listed the three mediastinal compartments and the major structures that are found there and the masses that arise in those compartments. So let's go through the anterior one first. In the anterior mediastinum, that's where you find the thymus and the internal mammary arteries and lots of lymph nodes. Masses that arise here go by the mnemonic the terrible T's, and we'll talk more about this in a minute, but the reason they're called the terrible T's is because the masses tend to be thyroid, thymic neoplasms, teratomas, or terrible lymphomas. In the middle compartment, that's where you find the heart, the pericardium, the great vessels, the airway, the esophagus. Masses here are usually enlarged lymph nodes that can be from lymphoma or sarcoidosis. It's also a classic location for lymph nodes of metastatic lung cancer. And then finally, the posterior compartment contains the spine and the spinal cord and nerves. So masses back in this section are usually neurogenic tumors, things like schwannomas and neuroblastomas. So now let's talk about those anterior mediastinal masses that go by the mnemonic the terrible T's. Masses that arise from the thymus are half of all anterior mediastinal masses. One of the classic ones is a thymoma. This often occurs in association with myasthenia gravis, and I talk more about this in videos on neuromuscular junction disorders in the musculoskeletal section. Teratomas or germ cell tumors in adults develop in the anterior mediastinum. This is the most common location for an extranodal germ cell tumor. So many germ cell tumors arise in the testes or the ovaries, but some of them arise outside of those areas. Those are called extranodal germ cell tumors, and the most common location is the anterior mediastinum. So you can see teratomas here and also seminomas, which are a germ cell cancer. Lymphomas often develop here. They go by the mnemonic terrible lymphomas to fit with the four T's. And then finally, thyroid growths can occur in the anterior mediastinum, causing a mass. Some patients have enlarged or ectopic thyroid tissue that arises here. It's usually connected to the thyroid gland. Next, let's talk about the diaphragm. So the diaphragm is a muscular structure that separates the thorax from the abdominal cavities. So any structure that needs to pass from the chest into the abdomen needs to go through an opening in the diaphragm. And there are three important structures that need to pass from the chest into the abdomen, and each one goes through an opening in the diaphragm. The openings are called a hiatus. So the inferior vena cava goes through here. This is called the caval hiatus. The esophagus goes through right here. This is called the esophageal hiatus. And then finally the aorta goes through right here, and this is called the aortic hiatus. The openings in the diaphragm are not all found at the same level of the thoracic spine. Remember that the diaphragm is dome-shaped, and therefore you can find some openings that are higher and others that are lower. The first opening is the caval opening. This is found at T8, and this is where the inferior vena cava passes through the diaphragm. And it's easy to remember that this is found at T8 because vena cava has 8 letters in it. The second opening is the esophageal hiatus. This is found at T10. The esophagus passes through here and also the vagus nerve. And it's easy to remember that this is found at T10 because the word esophageal has 10 letters in it. And then finally, the aortic hiatus is found at T12. This is where the aorta passes through the diaphragm, also the thoracic duct and the azygos vein, and it's easy to remember that this is found at T12 because the words aortic hiatus have 12 letters in them. The diaphragm is innervated by the phrenic nerve, which arises from C3, C4, and C5, and many people remember the mnemonic C3, 4, and 5 keep the diaphragm alive. Now, these nerves also sense pain from the shoulder, and what this means is that if there is irritation of the diaphragm, this can lead to pain that is perceived as being in the shoulder. This is called referred pain. So even though the irritation is with the diaphragm, the pain is referred to the shoulder and the patient will complain of shoulder pain. The classic example is gallbladder disease. Some patients who have cholecystitis will complain of shoulder pain when it's actually their gallbladder. That's the problem, irritating the diaphragm. Lower lung masses can also do this. And then finally, if the diaphragm becomes irritated, this can also cause dyspnea and hiccups. And this is because the diaphragm begins spasming and not contracting appropriately. If the phrenic nerve is cut, and this sometimes happens during thoracic surgery, this will lead to the diaphragm being elevated on one side. It will also lead to dyspnea because the patient won't have normal contraction of the diaphragm. If you examine the diaphragm during inspiration, what you see is what's known as paradoxical movement. One side of the diaphragm goes down during inspiration. That's what should happen. But the side where the nerve has been cut will go up actually. It's pulled up by the other side, so it moves up with inspiration. And you can see this on fluoroscopy. It's called the sniff test. If you think a patient has had damage to the phrenic nerve and they're complaining of shortness of breath, you have them take a sniff of air in under fluoroscopy, and you will see that paradoxical movement, and that's how you can diagnose phrenic nerve damage during a thoracic surgery. So now let's talk about how we use our muscles when we breathe. Quiet respiration is the term used to refer to breathing you do when you're sitting and not thinking about breathing. It's the automatic sort of breathing that your body does. And this type of respiration is entirely performed by the diaphragm. The diaphragm contracts, and that draws air into the lungs for inspiration, and then the diaphragm relaxes and air flows out of the lungs as a passive exhalation process. When you exercise, however, you start producing lots of carbon dioxide and your lungs want to ventilate more, so they will draw in other muscles so that more air can be pulled in and blown out. Muscles that are added in during exercise include muscles in the neck. These are muscles like the scalenes, which raise the ribs, and the sternocleidomastoids, which raise the sternum. Also, muscles of the abdomen are used to make a more forceful exhalation. This includes the rectus muscle, the internal and external obliques, the transverse abdominis, and the internal intercostals. And when patients are in respiratory distress, for example, a patient with pneumonia or heart failure, or maybe pulmonary embolism, you will see them using what's known as accessory muscles. All these muscles on the slide here are accessory muscles. They're not normally used during inspiration and expiration, but in patients in respiratory distress, trying very hard to move oxygen in and out of their lungs, you will see them using these extra muscles of breathing, and we call that use of accessory muscles. It's a sign of severe respiratory distress. And that concludes our video on pulmonary anatomy.